Hello. So we're going to continue now for medications for peptic ulcer disease. So we're going to be talking about diseases of the stomach. So in this case, I will emphasize the class on the PowerPoint presentation. So let me share the screen. There you go. So drugs for peptic ulcer disease. So peptic ulcer disease is considered a group of GI disorders: gastritis, reflux, GERD. And all of them, what they have in common is an erosion of the gastric wall. And this happens because of an imbalance between the mucosa of the stomach and whatever is attacking the stomach. It could be too much acid. It could be an overstimulation of the acids. It could be an infection. So again, peptic ulcer disease is an ulcer, it's an erosion of the gastric walls due to infection or hypersecretion of acid. So yes, real quick, the reason the stomach doesn't get ulcers because gastric acid is because it has a mucus lining. And this mucus prevents that erosion, that ulcer. And acid cannot cross it. So anything that is able to interfere with the production of this mucous wall, of this lining, eventually will be able to produce an ulcer. So let's go down here on the bottom, prostaglandins. Prostaglandins is the reason we are able to secrete mucus. So prostaglandins are very important for the production of that mucus lining. So we need to consider that. You need to remember that prostaglandins, that chemical, is the reason we are able to make this mucus lining, and so forth, we don't get damage of the gastric wall. If something interferes with prostaglandins, if something blocks the production of prostaglandins, then we cannot make a mucus lining, and we're gonna end up with an ulcer. What else it helps prevent or controls that acid environment inside the stomach? Carbonate. Carbonate is also released in the stomach once we finish digestion. Every time we eat, the food stays in the stomach 30, 45 minutes, and then it's able to move forward into the intestine. The intestine doesn't have mucus. So before that happens, the stomach has to make sure that all the food that was digested in there moves forward to the intestine without acid. So before that happens, there's a carbonate flow in the stomach, neutralizes the acid, and now that food bolus can move forward into the intestine. So that's how it works normally. So here, one of the most common causes, now talking about the disease of the peptic ulcer disease, is an infection. The most common bacteria that you're going to hear is Helicobacter pylori or H. pylori. Not going to emphasize much here. Yes, that is a gram-negative bacteria that is able to survive in that acid environment and eventually is able to destroy that mucus layer and produces ulcers. Also, I like to highlight this. H. pylori is the #1 cause for gastric cancer. So probably people that they always have heartburns. And having heartburns, well, it's a normal condition based on our diet. But it's not normal when that heartburn goes on and on for weeks and months. Unfortunately, we can prescribe ourselves. We can go to a pharmacy and buy antacids, Tums, If you're Mexican, sal de uvas picot, and so on. So when you do this per years, something's not right. And that's when you have to go to see a doctor to see if you don't have an infection. Most of the patients that have heartburns for 3, 5 years, a very high percentage, close to the 90%, they have H. pylori. And like I mentioned, it's an infection, it requires antibiotics. If this diagnosis is not made, then that constant infection per years is going to evolve into cancer. Another cause for have an imbalance in the stomach and have an ulcer is the use of NSAIDs. And well, NSAIDs means non-steroid anti-inflammatory drugs. That's why NSAIDs stands for non-steroid anti-inflammatory drugs. So that means that also steroids can produce ulcers. Why? Because NSAID and steroids, they block the production of prostaglandins. So prostaglandins, they produce pain. Prostaglandins, they produce inflammation. Unfortunately, prostaglandins is also used by the stomach to make that mucus. So when someone has pain, when someone has inflammation, and they start abusing of NSAIDs and steroids, well, yeah, the pain and the inflammation goes away, but unfortunately, the prostaglandins in the stomach are also affected. So we inhibit prostaglandins with those two groups of drugs. We take that mucus layer away, and now the stomach is not making mucus and bicarbonate. So we're gonna have an ulcer. That's why when we talk about medications, the best way is empty stomach for absorption. If they have some type of discomfort with water, long-term use with food. And we see this a lot with patients taking NSAIDs like Tylenol, Motrin, naproxen, ketorolac, and so on. When they abuse, and again, and the culture here on the border is very common, the abuse of NSAIDs, then the consequence is going to be a peptic ulcer. Other reasons for having peptic ulcers is a severe gastric acid problem. It could be a tumor, and we call that Zollinger-Ellison syndrome. This is a tumor that produces a lot of gastric acid. What else is common to see ulcers with? People that smoke. Also, they smoking, all those chemicals, they also disrupt the production of prostaglandins. So now the stomach is unable to make mucus and bicarbonate. So in a nutshell, most common causes of ulcer: infection and NSAIDs, the abuse of NSAIDs. Okay, so how do we treat the infection? With antibiotics. Again, I'm just gonna highlight what is important of the antibiotic, and eventually when we get to the chapters next week, I'll throw more stuff in. So regarding the treatment of H. pylori, well, the diagnosis for first is a breathing test. H. pylori, just like everything that is alive, is gonna have a waste product that is called urea. The waste product of H. pylori is urea. And urea in this environment with the bacteria is in a gas form. So when we think that the patient may have H. pylori, we do a breathing test. It's very similar to we try to check for alcohol without doing a blood test. It's very similar to that. It's a machine that we uh, provide to the patient, and we tell them, okay, please blow into the machine, and it's going to measure the levels of urea. The other ones, okay, now it will be a blood test, and here we're looking for antibodies against H. pylori, or we can look for H. pylori on stools. Always the best one to diagnose an infection is going to be a blood test. If we want to be more invasive, then we'll do a endoscopy, and that way you can go to the stomach and see the damage done by H. pylori. We're not going to see H. pylori. We're going to see the damage done. We're going to see the inflammation. We're going to see the bleeding and the lack of mucosa in the stomach. Okay, so regarding the treatment for H. pylori, it's a combination of antibiotics and antacids. Where regarding antibiotics, we have clarithromycin, amoxicillin. Bismuth is not an antibiotic. Metronidazole and tetracyclines. And they have to be combined. None of them are effective by themselves. Okay, so regarding clarithromycin, this is a medication that is very, very heavy on the stomach. So when the patient takes clarithromycin, we need to let them know that they will have a sensation of nausea, vomiting, and they may have diarrhea. Worst case scenario, abdominal cramps. So clarithromycin is very, very heavy on the stomach. Regarding amoxicillin, in the antibiotic world, it's a very noble antibiotic, not a lot of severe side effects besides the presentation that is PO, so that would be NBD. But regarding amoxicillin, you need to understand that from all the antibiotics, this is the one the patient has the most uh, allergies to. All the penicillins. Amoxicillin is a penicillin. So before we give amoxicillin, we have to make sure that the patient is not allergic to any of the penicillins. So I'll put it right here. And we have to ask also for cephalosporins. They have a cross allergic reaction. So if the patient is allergic to penicillins, they will be allergic to cephalosporins. If the patient is allergic to cephalosporins, they'll be allergic also to penicillins. So regarding amoxicillin, that will be the main question. Are you allergic to penicillins? Or are they allergic to cephalosporins? If the patient is not allergic, they're gonna give you a face like, I don't understand what you're saying. But if the patient is allergic, this patient is gonna be very familiar with penicillins and cephalosporins. So that'll be the highlight regarding amoxicillin. Let me go down here. Tetracyclines. Tetracycline is an old antibiotic. It's one of the first ones that were developed. The highlight of tetracycline is it cannot be mixed with dairy products. Tetracyclines, they love calcium. So tetracycline, when it's mixed with a dairy product, milk, cheese, they will attach themselves to calcium, and now tetracycline plus calcium is a bigger molecule and will not get absorbed. So it's not going to work. So if the patient is getting a tetracycline, we must insist, don't take it with milk or cheese. What is the best way to take a tetracycline? Empty stomach. Patient tell you, well, I have gastritis. Every time I take a pill, it hurts. Then, okay, let's try to convince the patient to take it with water. But I can't already have an ulcer. So they need to take it with a snack. And that snack has to be dairy-free, or the milk is just not going to be absorbed. Okay, now let's go to what happens with this medication is absorbed by the body. So the patient takes a tetracycline as indicated, and they take it with crackers, so no problem there. Tetracycline gets absorbed, and like I told you, tetracycline loves calcium. So where do we have calcium? In the bones. So tetracycline is gonna start attaching itself to calcium, and it's gonna take that calcium away from the bone. So tetracyclines are not advised to be used on kids. Why? Because they need that calcium to grow. So it's not advised in children. It's not advised in pregnant patients. And not because of the mom, it's the fetus. Same thing. The fetus needs calcium to develop a proper skeletal system. If we give a tetracycline to that pregnant mom, we're going to interfere with that calcium absorption by the fetus, and the fetus is not going to develop properly. Usually they're shorter. And same with kids, or a toddler. If we give a tetracycline, especially long-term use, we're going to affect bone development, and that patient, that pediatric patient, is not going to develop properly. So how do I know this patient is having a tetracycline toxicity? The first thing is going to be stains on teeth. So that's how I know this patient now is having a complication from tetracyclines. The teeth, they're going to start showing stains, and that's when we have to cancel the antibiotic. So again, tetracyclines, don't take it with dairy products, take it with crackers. And tetracycline is contraindicated on patients that are pregnant and pediatric patients. And then we have metronidazole, Flagyl. Flagyl or metronidazole, some authors consider it antibiotic. Other authors consider them an antiparasite. Some authors just say, you know what, screw it, it's both of them. It can kill bacteria, and it can kill parasites. So in this case, they can be used to kill a bacteria like H. pylori. The highlight regarding metronidazole is it cannot be mixed with alcohol. It cannot be used with alcohol. So if this is an adult that has the habit of taking a glass of wine and dinner, we need to let them know you cannot take alcohol when you're taking this drug, because you're going to have a disulfiram-like reaction. The first time we saw disulfiram is when we were talking about patients trying to stop drinking. It's a patient that doesn't want to continue drinking, and they go to the AA meetings. And once they finish that, they'll go to a doctor, let them know, hey, you know what? I'm done drinking, but I guess I need help. If there's a drug to help me, and the sulfuram, we mentioned that there, it's a drug that when they take it and they decide to celebrate because it's 6 months without having a beer, and they take a beer, they're going to have severe nausea, vomiting, and headaches. So the same reaction we have with metronidazole and alcohol. So we need to make the patient aware of that. Okay, tinidazole, this is another variation of metronidazole. It's a new version, and same thing, the sulfiram-like reaction. Now let's go to bismuth compound. This is Pepto-Bismol. Bismuth compounds is Pepto-Bismol. It's not considered an antibiotic, but this medication is able to break the walls of H. pylori. So when a patient has an infection by H. pylori, it's going to get a combination of the antibiotics that I mentioned, plus Pepto-Bismol. Now regarding here, the abuse of Pepto-Bismol is going to produce black coloration of tongue and stools. It's gonna take longer to produce a discoloration of the tongue, but I'm gonna see a 24-hour, 48-hour effect on the stools after they start taking the Pepto-Bismol. So the patient has to be aware that the stools are gonna be black. And the problem is nowadays that every time I have a symptom, I'm gonna Google it, and if I put their black stools, it's gonna say GI bleeding. The most common cause is GI bleeding. And they're gonna go to the ER all scared because they're bleeding, and they have a history of a gastric ulcer, and they get all paranoid. So if they're taking Pepto-Bismol, we need to emphasize, hey, when you take this medication, maybe tomorrow or the day after tomorrow, your stools are gonna be black. And long-term therapy, if this patient decides, hey, Pepto-Bismol is good, I don't want to have, trouble with my stomach, I'm gonna take it for the longest time. It's OTC, so what may happen to me. Pepto-Bismol do uh can do damage to the axons of the neurons, and we don't have proper transportation of those signals. So if the patient has a peptic ulcer because H. pylori, that is the treatment. So up here. So again, patient is going to take a combination of clarithromycin, amoxicillin, Pepto-Bismol, metronidazole, and tetracyclines. Usually the treatment is a week. Okay. Unfortunately, infections is not the only cause of gastric ulcers. Another reason for having a gastric ulcers can be a hypersecretion of acids. For some reason, the stomach is being overstimulated and it's making too much acid. No infection. So if the problem is hypersecretion, I have to give medications that are gonna block that stimulation of making too much acid. And we have two main groups of drugs. The first one is histamine 2 receptor antagonist. So this means that histamine stimulates the stomach to make acid. And we emphasize histamine 2. Because if you remember correctly, regarding allergies, the reason of allergies is histamine. But the receptor that are stimulated is histamine 1. So when we have allergies, I want to block histamine 1 receptors. If I'm making too much gastric acid, I want to block histamine 2 receptors. And here we have the most common drugs used: cimetidine, ranitidine, famotidine, nasotidine. So histamine 2 receptors, they end in tidine. So that's how you know, tidine. And Pepcid, Zantac, those are brand names that probably you're very familiar with because they're OTC. So people with a hypersecretion of acid, they can go without a prescription and get this type of drugs, OTC. And again, what happens when I take a histamine 2 receptor antagonist? I'm blocking the receptor, and by doing that, I'm blocking the production of acid. If we have to put this into numbers, I'm blocking like a third of the production of acid, more or less, just to give it a number. It's not 100%. So histamine 2 receptor antagonists, when they're used, usually they decrease acid production by 1/3. Usually histamine 2 receptor antagonists is the first choice when we know that it's not an infection. Let's see, regarding excuse me, therapeutic uses, any condition where there's too much gastric acid. Gastric and duodenal ulcers, GERD, Solinger-Ellison syndrome, this is a tumor, aspiration pneumonitis, heartburn, acid indigestion, sour stomach. So any condition where there's too much acid, we can use the histamine 2 receptor antagonist. So what is the problem? Unfortunately, cimetidine can produce anti-androgenic effects. So androgenic means to provide male characteristics to a body. So anti-androgenic effects for the male, it would be gynecomastia, man boobs. So cimetidine produces man boobs. Also can decrease libido. Don't mix it with warfarin because it's going to block the effect of warfarin. Warfarin is a blood thinner. And don't mix it with antacids. Even though antacids is also to control the acid inside the stomach, it's not a good idea to mix them together. And regarding this type of drugs, the best advice is always take one first, wait an hour, and take the other one. So unfortunately, our senior population, they have a pharmacy on their nightstand. And it's always better to tell them, hey, you know what, take your drugs for whatever condition you have, and then take the antacids an hour later. So that's the most common advice if they're taking antacids. Take those last. Regarding ranitidine, the only risk that we see here, long-time use, is the risk of pneumonia. And let me explain this. How did this work? The thing is, gastric acid also protects the lungs. I know it sounds weird because the stomach is down here, the lungs are up here, or the windpipe. But the thing is, every time we make gastric acid, around 10% turns into gas. So as a gas, it's able to come up the esophagus and kill the bacteria that we have on the pharynx, on the throat. Something that the books they don't mention, but is when you do your research, is known that gastric acid, 5–10%, it will be turned to gas, and that's how it protects us. So if I'm blocking the production of gastric acid, now my stomach is not that acid. So that means that amount of gas from the gastric acid that used to go up, now it's not sufficient enough to kill the bacteria in my throat. So now that bacteria is going to go down my windpipe into the lungs, and that's how we see pneumonia. Gastric acid is a normal barrier against infections, and that's how gastric acid protects the lungs. Funny thing, huh? Ranitidine, just like cimetidine, same thing, is used for any condition where we have too much gastric acid in the stomach. Okay, let's jump now to the next group, the protopump inhibitors. This is the best of the best if I want to block gastric acid production. This is a medication, protopump inhibitors is the only medication that blocks 100% the production of gastric acid. So they are very effective when I'm trying to treat an ulcer. So here's how it goes. Protopump inhibitors, they have to be used short term only. My advice, a week to 2 weeks. That's it. Excuse me. Why? Because this medication is blocking acid 100%. So what happens? The patient eats. There's no digestion. So all those nutrients, they're not broken down. The food will move into the intestine, but the intestine will be unable to absorb all those nutrients, vitamins, uh, carbohydrates, fats, and so on. So if I have a patient that is abusing of this group of drugs, they're going to go into malnutrition. So long-term use of proton pump inhibitors is malnutrition. So it took a while for doctors to realize that proton pump inhibitors they're good only on a short period of time. Omeprazole is the first one, and all proton pump inhibitors they end in prozole. So we have omeprazole. We have over here esomeprazole. That's Nexium. Esomeprazole. Lansoprazole. This is the only one that is IV. This lansoprazole and so on. So pro-pump inhibitors, all of them, they end in prozole. When they are used short term, the adverse effects, they only correspond to the presentation, PO. So it means MVD. That's it, nausea, vomiting, diarrhea. If we go long term, then we're going to have malnutrition. We're going to see deficiencies in vitamin C, vitamin K, vitamin B, vitamin A, and so on. So, on my personal experience, 1 to 2 weeks, and that's it. Rabeprazole, that's another one. Pantoprazole, and so on. So that'll be everything regarding proton pump inhibitors. This is the only drug that can block the production of gastric acid 100%. So if I want to heal this patient fast, that's the best drug. Okay, what other drugs we have to treat the ulcers, anti-ulcers? So we have sucralfate or carafate. Sucralfate is it's very similar to Pepto-Bismol. The consistency of it is very similar. And this medication, when you take it, the acid is gonna make it slimy, and it's gonna attach to the surface of the stomach. So it's gonna create basically a barrier. It's a slimy barrier. And carafate or sucralfate is gonna lay on top of the ulcer, and it's gonna protect it from the environment. This medication only lasts up to 6 hours, so basically we can tell the patient take it 4 times a day, every 6 hours. Adverse effect will be constipation, but again, it's not significant, only 2%. So sucralfate is a very good option to treat ulcers. And then we have misoprostol. Misoprostol is a synthetic prostaglandin. And we mentioned earlier that prostaglandins, they make the mucus layer. So if this patient has an ulcer and we want to accelerate the production of that mucus, I'm going to provide prostaglandins, misoprostol. The highlight, don't give it on a pregnant patient. Unfortunately, misoprostol will stimulate labor contractions on that month. So when misoprostol is going to be given to a patient, a female patient, we must make sure the patient is not pregnant. Because again, prostaglandins in the uterus promotes labor contractions. So in the stomach, it's amazing because accelerates the production of that mucus layer, that mucus lining. But if the patient is pregnant, then it's gonna produce labor contractions, and that baby is gonna be born prematurely. So that'll be the highlight with misoprostol. Don't give it to pregnant patients. Okay, now let's jump to the antacids. Antacids, what they do, they inhibit, excuse me, they inhibit the acid in the stomach in that moment. And that's it. They don't stop the production of acids. So antacids is a quick fix. Antacids cannot be used long-term because they don't provide a long-term therapeutic effect. It's only a quick fix. So antacids overall, they cannot be mixed or taken at the same time with other drugs, not just the ones that we have here. It could be antibiotics, it could be warfarin, it could be medications for hypertension, for glucose. Antacids, they will block the acid from the stomach, and we need that acid to break the other drugs in order to be absorbed. So if the patient is taking antacids plus other drugs, we need to let them know. Take your other medications first, wait 1 hour, and then take the antacid. Now, regarding the antacids, the main component are minerals like aluminum, magnesium, and sodium. And here's where we have to be careful with a patient. Regarding antacids with aluminum, the adverse effect is going to be constipation. We need to let that patient know that when they take this type of antacids, aluminum, they're going to have constipation. If the antacid has magnesium, they're going to have diarrhea. Now, regarding magnesium, magnesium cannot be given to patients with kidney failure. Magnesium blocks the action potential. It doesn't let sodium go inside the cell and produce an action potential. So patients with kidney failure, they cannot eliminate magnesium on time. Magnesium is going to accumulate and it's going to block the action potential from the muscle. So the patient's going to feel weak. It's going to feel flaccid. Magnesium doesn't affect the heart, affects skeletal muscle, smooth muscle. What is that muscle that I don't want to stop moving besides the heart? And that will be the diaphragm. So if the patient has kidney failure, we cannot provide an antacid that has magnesium. And regarding antacid with sodium, that's a sodium bicarbonate. The thing with these ones, they work very, very fast. They're very good, but they're water soluble. So that means that when we take sodium bicarbs, they'll be absorbed by the body, but they will stay in the vascular system holding water. So this type of antacid with sodium carbonate is not advised for patients with heart failure. So again, regarding antacids, we have with the aluminum, adverse effect will be constipation. Magnesium, adverse effect will be diarrhea, not to be given on patients with kidney failure. Also, we have TUMS, calcium. Usually adverse effects, they're not severe. If the patient has kidney failure, then we're gonna see muscle spasms. Antacids with calcium, TUMS. If the patient has kidney failure and we have an accumulation of calcium, the patient's going to have muscle spasms. And antacid with sodium is not advised on patients with heart failure. Okay, so we already talked about all this. Okay, and we are done with this chapter. Thank you very, very much for your attention, and I'll see you on the next chapter.